Welcome to Essentials of Pharmacology. This is a course I think you're really going to enjoy. I primarily put this course together for complementary health practitioners because this course really deals with the essentials of what someone doing nutritional medicine consulting. You know, many of the patients that you see are going to be on medications, and it's very important to understand what those medications are doing, what are the key potential side effects, what drug-nutrient interactions are there. So this is a course that really is Essentials of Pharmacology that's really aimed at someone who's going to be doing nutritional medicine counseling with the patient, lifestyle medicine coaching. Having some background in what pharmaceuticals can do is absolutely critical. On your intake questionnaire, you're going to be asking people what medications are you on, and if you don't know what those things are, what they do to the body, and what potential side effects are the most critical ones for the different classes of drugs, then you're really to a large degree in the dark. So we'll examine the reasons why this is so important as we start this program. So why study pharmacology at all? A lot of people say, I'm not going to be prescribing drugs. That's not what I do. I'm a natural healer. But the reason why it's important to understand it is because many of the patients or clients that you see are on medications. And so you should really know the effect of each drug, the effect that it's having on the patient's physiology before you make any dietary, exercise, or supplementation recommendations. For instance, if a person is doing aerobic exercise and they're on a beta blocker drug, then you have to change the target heart rate zone. You have to adjust it down by 10% because the beta blocker is having this attenuation effect on how the heart is responding to adrenaline and norepinephrine. So there are some things that are just mandatory to know. And you should also be on the lookout for drug side effects that are masquerading sometimes as the primary health condition. The person comes to you and they have ringing in their ears, like tinnitus. It could be just from use of aspirin. Or the person suddenly starts to develop aches and pains and back pain, and you're looking for problems in that area. And recently you find out they just started on a statin drug where anywhere from 10 to 30% of people can end up with myalgic pain from being on a statin drug. These are things that you should know. And sometimes the patient's physician will actually miss these things. And so the healthcare system needs a second set of eyes on all of this. So there are really 8 important drug supplement considerations that must be factored in to the dietary, exercise, and supplementation recommendations that you are going to recommend. So the 8 key drug supplement considerations really are these. To appreciate that, some drugs can do things that supplements cannot do. There are drugs that are muscle relaxants, like methylcarbamol, like you would see in, say, robaxisol or robaxacet. And there really aren't any supplements that can do that. Some drugs can do things that supplements can't do. By the same token, some supplements can do things that drugs cannot do, like rebuild cartilage, increase the synthesis of acetylcholine in the brain. There are no drugs yet that can do that, but there are supplements that have been shown to do it. Some supplements work synergistically with a particular drug, which then allows the physician to reduce the drug dosage where the drug is known to produce adverse side effects. So, for instance, we know that taking acetaminophen at certain chronic doses is the leading cause of drug-induced liver failure in the United States, or at least acetaminophen is. In at least 50% of the cases, the person's using it in just the usual doses. But if you could decrease the person's reliance on acetaminophen by giving them other things that naturally reduce inflammation and pain so they don't need as much of a dosage, then you're helping to mitigate drug side effects. Number 4, supplements can potentiate the effects of drugs, producing serious adverse effects. So in other words, sometimes a drug-nutrient interaction is a serious one, whereby the drug is already doing a particular thing, and then you give the person a supplement that also amplifies the same effect. And if it's an anticoagulant drug and a supplement that also has powerful anticoagulant properties, you end up increasing the risk of an internal bleeding disorder. Or if it's a drug that's increasing the serotonin levels in the brain and you give the person supplements that increase serotonin levels further, the person can go into life-threatening serotonin syndrome. So some supplements can potentiate the effects of drugs, producing serious side effects. And this is why this is a course that's really mandatory for anyone that's going to get into the nutritional and lifestyle counseling area. Now, some supplements also reduce the efficacy of a drug by stimulating its detoxification. A woman on a birth control pill who feels a little depressed, decides she wants to take some St. John's wort, is speeding up the rate at which her liver detoxifies the birth control pill, and there's a greater chance that she's actually going to get pregnant. And she thinks the pill is protecting her, but no, it isn't. And some supplements are completely contraindicated in certain health conditions. A person with Wilson's disease who has a copper storage problem, and taking a multivitamin that has copper in it would be, a serious oversight. Same, someone with hemochromatosis taking iron from a supplement, also very similar. So there's some supplements that are just absolutely contraindicated in certain health conditions. And sometimes certain supplements require specific monitoring or physician approval in specific cases. The person's had a kidney transplant and they're on immunosuppressant drugs, or a liver transplant, or they have cancer presently. Sometimes there are certain things you might want to do. You just need to get physician approval before you actually start going down that road. And in women who are pregnant or breastfeeding, certain supplements should be removed from the repertoire of supplements, and possibly other ones you might want to put in place to actually improve the brain development of the fetal body, or help a woman decrease the risk of a neural tube defect, or to decrease risk of postpartum depression. So once a woman's pregnant or breastfeeding, you need to factor that into the equation as well. So all of these are the 8 major considerations that I see where someone who's doing nutritional medicine counseling needs to have a background, at least in the essentials of pharmacology. So here's a brief history of drugs that I found quite fascinating. The pharmaceutical industry, which we take for granted today, you drive down the streets, you see drugstores and open all night drugs, open 24 hours drugs, and if you ever looked at the compendium of pharmaceuticals, that book when they printed it, there's just thousands and thousands of drugs. But drugs have only really been around in the form that we know them as pharmaceuticals since 1941. It was really it's like around 80 years roughly or less that you even actually have pharmaceutical drugs. So we take it for granted that they've always been here. It really happened when Chain and Florey during World War II discovered that penicillin could be taken orally, ingested to fight bacterial infections. Prior to that, in 1928, it was Alexander Fleming who discovered that these penicillin spores that had become airborne from a lab below his lab sort of floated up, and they landed in a petri dish. He was studying the Staphylococcus bacteria, and he noticed that all of a sudden that these bacteria stopped replicating. Something was blocking their replication. It was some accidental inoculation. And as he looked into it, he realized that these penicillin spores were actually stopping the bacterial growth. It was an accidental finding, but it actually triggered the whole pharmaceutical movement. So until 1941, though, between 1928 and 1941, penicillin, they just thought you could use it topically, for wounds to decrease infection. But it was Chain and Florey in 1941 who discovered that it could be used internally. And this was really the birth of the pharmaceutical industry. However, prior to that, drugs like digitalis were around. They were just, they were phenolic glycosides that were removed from the foxglove plant. So you had this sort of plant-based pharmaceutical industry. A lot of herbals, some of these things were extracted from plants and being used. But in terms of the synthetic drugs that we have today, this started, not until the 1940s. And so in a very short period of time, 80 years or less, the pharmaceutical companies have convinced medical doctors and most of the modern world to ignore all the previously known information around natural remedies and focus only on these synthetic drugs that they produce. Now, prior to 1941, only natural medicines were actually available to treat certain patients. So if a person had tuberculosis or infections, they might give them colloidal silver. Now, in fairness, antibiotic drugs are way more effective at treating tuberculosis than colloidal silver. So there's been some tremendous improvements, but at the same time, some of the natural agents that were used originally still have a tremendous value in our healthcare system today, and they're largely ignored in conventional medicine, and that really has been the problem, that sometimes patients are not getting the best advice or understanding how to combine the best of both worlds to get the best health outcome. And that's why you'd be involved in looking at nutritional medicine in the first place, because you've identified that. So the pendulum has swung so far to one side that natural remedies really got dismissed along the way. But really in recent years, the use of and search for drugs and dietary supplements derived from plants has actually accelerated again. So pharmacologists and microbiologists, botanists, and natural product chemists are really combing the earth for phytochemicals and leads that could develop into a treatment for various diseases. So we're seeing catechins from green tea and resveratrol, and extracts from saw palmetto and CDP choline, and we're starting to discover that there's some invaluable natural agents that exist in this world that can be very helpful in preventing disease and improving outcomes for patients that have certain health conditions. Glucosamine is another example. And in integrative cancer therapies, because I taught in the Integrative Cancer Therapy Fellowship Program for the American Academy of Anti-Aging Medicine, many of those integrative medical doctors and oncologists who take those programs are using targeted supplements. When we get into the cancer section on this platform, I will lay out for you the integrative medicine evidence-based information, a lot of which you will find, I think, quite fascinating. So there's also the impact of adverse drug effects. So when you have so many pharmaceuticals and you have so many people on polypharmacy, so many drugs being prescribed, the Institute of Medicine found that as many as 98,000 hospitalized Americans die every year, and 1 million more are injured as a result of preventable medical errors that cost the nation an estimated $29 billion. Adverse drug reactions in the year 2000 were the fourth leading cause of death in the United States. It's probably the same today. More common than breast cancer, AIDS, or traffic accidents. At that time, it was costing $170 billion a year. Adverse drug reactions. In addition to these costs, the Centers for Medicare and Medicaid stated in a recent report that the nation spent, this is in 2000 again, over $140 billion in the year 2000 on prescription drugs. And then you add to that over-the-counter medications, and these numbers are staggering, $140 billion in the United States. So, when pharmaceutical companies have a great deal of lobbying power and they're able to influence a lot of the medical training, this is not a conspiracy, it's just sort of the way it's evolved. And a lot of the nutritional medicine, natural medicine things really have got left behind. And a lot of nutrition, natural medicine things should have gotten left behind, because there's a lot of nonsense out there. But where you have, good evidence that certain things can be used to enhance people's health outcomes. And for me, it seems like a huge oversight that medical doctors don't get more training in evidence-based nutritional medicine as part of their program. And so you have this sort of a divide, unfortunately, and the patient is not sure exactly what to do. The doctor says, there's no evidence for any nutritional or natural medicine. This is all hocus pocus. And then you have people who have an in-depth understanding of it, who have convincing arguments, and the patient says, that makes a lot of sense to me. So, more and more people, though, are looking for some nutritional medicine solutions to their problem. As you assess people and make recommendations, it's very important that we do things in a way that's very responsible. And part of that responsibility means having a working knowledge of essentials pharmacology, and that's why this course exists. So I'm not a pharmacologist, I don't have a PhD in pharmacology, but I have enough basic understanding that I can share this with you so that we're all on the same page and we're sort of practicing in a way that is responsible and giving patients, the best chance to have a positive outcome. So let's look at some of these drugs. I broke them up into different classes. We're going to look at cardiovascular drugs and diabetic drugs and mental health drugs and drugs for gout and drugs for Parkinson's. We're going to see the whole gamut. What I really want you to understand is how the drugs work. So when you see a person who's on a particular drug, and you're not going to remember all the names, but if you search it, it goes, oh, that's a calcium channel blocker. Oh, I know what that does. Or that's a statin drug. Oh, and I just want you to understand what the drugs do to the body. What is the mechanism? What doctors and pharmacists have to know is what the body does to the drug, right? Because the body then has to detoxify the drug in a certain way down a particular detoxification pathway. That's beyond the scope of this course. And then there's drug-drug interactions where sometimes two drugs are competing for the same detoxification pathway. So if they're competing, then there's a chance one of them is going to build up more in the system than what was intended and produce an adverse effect. So doctors and pharmacists have to have in-depth knowledge of that kind of thing. That's beyond the scope of what we're going to discuss here. What I want you to know is what is the mechanism of action that allows these drugs to have their effect? Which drugs have a greater risk of certain side effects that are fairly common, right? So beta blockers and erectile dysfunction, statin drugs and liver damage and myalgias, things that really stand out, so that you are sort of the second set of eyes in the healthcare system, so that doctors don't miss things. And also drug-nutrient interactions, because you're going to be discussing with patients nutrition and exercise and possibly supplements. You need to really have encyclopedic knowledge of important drug-nutrient interactions. So those are the things I'm going to emphasize and I'll point out, because those are the kinds of things that are exam questions. How does the drug work? What are really important side effects of a particular drug if something really stands out? And what are the drug-nutrient interactions to be aware of? That's the kind of clinical knowledge you need to carry forward into practice. So let's start with cardiovascular drugs. In the first section of this is going to be drugs that lower blood pressure, antihypertensive drugs. And so you see there's 6 of them: diuretics, beta blockers, calcium channel blockers, the ACE inhibitors. These are angiotensin converting enzyme inhibitors. And then the ARBs, the angiotensin receptor blockers. We'll see these. And then the renin blockers. And I've alluded to these in some other courses already, but now we'll really nail it down. So let's start with diuretic drugs. So diuretic drugs obviously elevate the rate of urination and water loss. When a person has high blood pressure, they're retaining water. One thing that they can do is give them a diuretic drug that's going to block the reabsorption of sodium and chloride from the kidney tubule back into the bloodstream. So more of the sodium and water stay in the kidney tubule, and if the sodium's there, it's going to pull water with it, and that will then decrease the blood volume of water. And so now, and you can excrete more water through the urine. And as the blood volume goes down, the thinking is that there's less total pressure in the system, so the heart doesn't have to work as hard, and there's less peripheral resistance, so the systolic and diastolic pressure go down. We think that's how diuretic drugs are working to reduce blood pressure. So about 21%, around 20 to 21% of all the cardiac output goes to the kidneys. We saw that in the kidney section on this platform. About 1,200 milliliters is the rate of blood flow through both kidneys in a 70 kilogram man per minute, 1,200 milliliters per minute. And of all the filtrate that gets filtered through Bowman's capsule, through the glomerulus, Bowman's capsule into the lumen of the nephrons, 99% of it actually gets reabsorbed. Only 1% of it actually ends up in the urine at the end of the day, provided kidneys are working properly. So we've seen this before, where we have Bowman's capsule, the glomerulus. You have the things are being filtered from the blood. This very high pressure system filters things in, and then sodium's resorbed, potassium and water and bicarbonate and glucose and amino acids, and then further along the other things are being absorbed down the descending loop through the loop of Henle, and then the thickened ascending loop. And we'll stop right there. Notice that 25% of all the sodium chloride is reabsorbed from the tubule back into the blood vessels, the capillaries, back into the bloodstream right there. So these high ceiling diuretics actually inhibit that sodium pump right there. And so if you block that, then less sodium chloride is going to get back into the bloodstream. More of it, the sodium will stay here, and that will draw water into the kidney tubule and lower the blood volume. so you can then excrete more water through the urine. Then as you come into the distal convoluted tubule, you'll see that about 5 to 10% of sodium chloride is also reabsorbed here. So the lower ceiling diuretics that work here have a more modest effect on decreasing sodium resorption. Then you also see other things are being reabsorbed here. And then in the state where aldosterone is turned on, you're going to have excretion of potassium into the kidney tubule. So we'll see the importance here of what are called potassium-sparing diuretics in a moment. And then, of course, you go into the collecting duct, and you have antidiuretic hormone here. If the blood volume is dropping, it'll be turned on, and then you'll actually reabsorb water to bring the blood volume back up. But remember that stress and caffeine and nicotine and alcohol all can inhibit antidiuretic hormones, so more water ends up in the collecting duct, and you urinate. There's more urination, of course. You increase urination. Stress, caffeine, nicotine, alcohol, all will have a diuretic effect by inhibiting antidiuretic hormone. So let's just think about this for a moment. If I have a diuretic drug that's stopping the reabsorption of sodium chloride right here, then the sodium stays here, and more sodium ends up in the distal convoluted tubule. And when that happens, it turns on the renin-angiotensin-aldosterone system. The body says, there's so much sodium here, where we need to try to reabsorb that. And as we try to reabsorb that, we're going to actually excrete more potassium into the lumen. And when you excrete a lot of potassium into the lumen, you can end up with low blood levels of potassium, hypokalemia. And hypokalemia can lead to heart arrhythmias and a sudden death heart attack, and increased risk of cardiovascular mortality. And so sometimes doctors will actually, in conjunction with a diuretic drug, particularly a high ceiling diuretic drug, which is blocking the reabsorption of like 25% of the sodium chloride, they know it's probably the body's going to respond by trying to reabsorb some of that sodium chloride here, and there's going to be this aldosterone kick. They'll give the person a secondary diuretic, which is a potassium-sparing diuretic that will inhibit the effects of aldosterone, so you don't secrete that potassium into the lumen to the same degree. So sometimes you'll see that doctors will combine things. They'll give the person a diuretic drug. They'll also give them what's called a potassium-sparing diuretic at the same time to prevent hypokalemia. So if they're on a diuretic, they will they'll watch the person's electrolyte values of sodium and chloride and potassium and calcium and magnesium and so on. But they're really keeping a close watch on that potassium, because if it drops, they know the person's at risk for a major arrhythmia and possibly sudden death. So sometimes you'll see them combine things, and that's what we're going to see on the ensuing slides here. So the high ceiling diuretics cause a substantial diuresis. Up to 25% of the filtered sodium chloride and water end up in the urine. These high ceiling diuretics work at the thickened ascending loop, which we just saw right here, right there. And so you can block up to 25% of the sodium chloride being reabsorbed. These loop diuretics are usually high ceiling diuretics, which inhibit sodium resorption at the ascending loop. We just saw that. Then there's low ceiling diuretics, these thiazides, which they have more of a modest effect because there's a more rapid flattening in terms of what they're able to accomplish relative to the high ceiling ones. So that the high ceiling loop diuretics that we see in the thickened ascending loop. Here's the thickened ascending loop here, right? So here's the loop of Henle. Here's the thickened ascending loop where 25% of the sodium chloride is normally reabsorbed. But if you block that pump, then that has a tremendous effect on decreasing blood pressure. Whereas the thiazide drugs are working at the distal convoluted tubule, and so 5 to 10% only of the sodium chloride is normally reabsorbed here. So it has a more modest effect, has a more modest effect on blood pressure lowering and diuresis. So it depends how high the person's blood pressure is or how much water retention is going on they'll decide high ceiling or low ceiling. And then, of course, preventing hypokalemia from diuretics. I've already explained that to you, so this slide basically says the same thing. As you inhibit the reabsorption of sodium chloride, more sodium chloride is going to end up in the distal convoluted tubule, and the body is going to respond and say, oh my God, there's so much, we have to try to reabsorb that. And in the distal convoluted tubule, the way that you do that is that the kidney juxtaglomerular cells secrete renin, and then renin is going to convert angiotensinogen into angiotensin, and angiotensin is going to be converted via the ACE enzyme, we'll see this later, into angiotensin 2. And angiotensin 2 then is going to, one of the things it does is it turns on it upregulates aldosterone. Then aldosterone in turn increases the reabsorption of sodium chloride from the distal tubule that you're seeing here, but it also increases secretion by the renal tubular cells of potassium into the kidney tubule, and that lowers the blood level of potassium, and that can cause hypokalemia, and that can be sort of a dangerous situation. That's what that slide is saying. And then hypokalemia is associated with increased risk of arrhythmias in patients with cardiovascular disease, as well as increased all-cause mortality, cardiovascular mortality and heart rate mortality by up to 10-fold. So you have to keep a close eye on that potassium. Derangements of potassium regulation often lead to neuromuscular, gastrointestinal, and cardiac rhythm abnormalities. So the normal level of potassium in the plasma is in this range that you're seeing here. The thing to know is that if the potassium level goes below that level, hypokalemia, or above that level, hyperkalemia, there's increased risk of cardiac arrhythmia. So being within that range is critical. And this is where I argue that, you need to be careful when you recommend things like potassium salts to people to use as a substitute, as a salt substitute. You start playing with potassium levels using, heavily fortified agents. You need to make sure you're not putting someone into hyperkalemia, not just preventing hypokalemia. And so the potassium-sparing diuretics, what they do is they sort of inhibit to a large degree, not all of them, but most of them work this way, like spironolactone. It's going to inhibit it's going to inhibit aldosterone function. It's going to antagonize the actions of aldosterone, as you see here. Some of them also work in a different way. Other potassium-sparing diuretics directly inhibit sodium channels associated with the aldosterone-sensitive sodium pump, and therefore have similar effect on potassium and hydrogen ion as the aldosterone antagonists. But they're still potassium-sparing diuretics overall. Because this class of diuretic has relatively weak effects on overall sodium balance, the question is, if these seem like a pretty safe kind of drug, they're sparing potassium so you don't develop hypokalemia, and they're also helping to, improve diuresis to some degree. Why don't you just use them on their own? And that's because they don't have a really strong effect on decreasing the blood volume. So they're usually used in combination with diuretic drugs to actually get the desired effect, lowering blood pressure or getting excess water loss out of the body, as might occur in somebody with cirrhosis or some other condition where body fluids are increased. So the potassium-sparing diuretics, they inhibit the secretion of potassium into the urine, often by inhibiting aldosterone or by blocking sodium channels. We just saw that on the previous slide. The effects of aldosterone promote the resorption of sodium into the bloodstream to increase blood pressure. At the same time, they're increasing the secretion of potassium into the urine. So if you block those two effects, you could actually inhibit sodium resorption back into the bloodstream and also inhibit potassium secretion, which would help to lower blood pressure. But it doesn't do it sufficiently on its own to be considered a significant diuretic type of drug. So they're usually in combination with other diuretic drugs. They're used together. So potassium-sparing diuretics counter these effects, and they're often used with diuretic drugs that otherwise tend to promote excess potassium loss in the urine. And the effects of hypokalemia, we talked about that. Diuretic drugs prevent sodium resorption but increase potassium loss in the urine, hence the risk of hypokalemia, and that's why if hypokalemia seems to be developing, often a potassium-sparing diuretic is used. And this is basically saying the same thing. And one of the classic ones that has been used over the years is spironolactone, which is a potassium-sparing diuretic that is an aldosterone antagonist. So you've got the idea here. So where would you use a diuretic drug? Well, patients with hypertension, it's uncomplicated. People in heart failure where the heart pump's getting weaker, fluids are backing up in the system, there's more strain on the heart, diuretics is there as well. In liver cirrhosis, when fluids are backing up, and in certain kidney diseases. Adverse side effects of diuretics. When people are on them, very often they feel very weak and tired. This lassitude and fatigue seem to be common problems that they report. So that's something to keep in mind. And also muscle cramps. When you start messing with electrolytes, you can get more muscle cramps. So it's important that the doctor keeps a really close eye on the electrolyte balance. And thiazide drugs can increase hyperuricemia. So sometimes it can trigger gout. Sodium is lost in the urine at the expense of uric acid. So more uric acid now accumulates in the bloodstream. If you're sensitive to gout, it could make it worse. Diuretic drugs tend to increase cholesterol, but the effect is so mild that it's largely negligible in the grand scheme of things. So that's not a huge concern. Of course, arrhythmias are a big concern because you can get hypokalemia. We talked about that. And also with excess loss of sodium and potassium, you can end up with metabolic alkalosis. Doctors are keeping an eye on this. But it's sort of this lassitude, fatigue, weakness, often due to the blood volumes drop so much people have just not enough fluid in the circulation generally, and this hypovolemia can set in. Muscle cramps, slight rate increase in uric acid associated with these drugs. Some of the common diuretic drugs, the first one that was ever invented was furosemide, or Lasix, and so the very first antihypertensive drug was a diuretic drug, and it wasn't created until the 1960s. So before the early 1960s, there were no drugs that could lower blood pressure, and so if you look at the stats on cardiovascular disease in the 60s, you see, man, it was super high. It has come down significantly since the 1960s. And one of the reasons is that, doctors are able to control blood pressure. Even if the person makes no lifestyle changes, doctors can, with the right drug combinations, often bring that blood pressure down substantially. You'd like to see the person get more involved in exercise and lifestyle change and other things, but if they're not willing to do it, these drugs are very effective. And we'll see the other ones that sort of can play into this. But the very first antihypertensive drug didn't appear until like the 1960s. And then you have the ones that were created later, like the thiazide drugs. And then we see other ones that have come along subsequent to that. So when we come back after the break, we'll pick up the story with the next class of antihypertensive drugs, which are beta blockers. So I'll see you then.